Good morning. It is so great to be back with you again. As I often say, this time we spend together here on Saturday mornings is the favorite part of my week, and I am so glad that you are here. We are going to be focusing on something today that is driven by an occurrence that's happening around the world. Tomorrow is World Lung Cancer Day, so that's where we begin the program today. Lung cancer is the world's #1 killer. Now, it's not the most common cancer out there, but it kills more people than any other kind of cancer. But it's not a hopeless situation. There is a lot of hope involved, and we're going to talk about that. We'll look at why is lung cancer so lethal, what does treatment look like, and what is the big breakthrough that we're all waiting for to really move the needle and help us all get past this. So all of that is going to be on the table today, and I hope that you'll join us either by phone or with a text question. You can always send your question to 46862. 46862 will get the question to us, and I will put that in front of our guest today, Dr. Ahad Sadiq. He is an oncologist with Fort Wayne Medical Oncology and Hematology. They are the area's most experienced team of oncologists. They have clinics in hometowns all over Northeast Indiana and also in Hicksville, Ohio. So thank you for coming in this morning.
Thank you, Lee. Thank you so much. It's a pleasure being here, and thank you for inviting me.
I am so glad to do it. There is a reason that's really pretty easy to understand why lung cancer is so deadly. What is that?
So, Lee, I think the biggest part that we see with lung cancer is, to be honest, is the smoking part. There are some cases which are genetically driven, but 90% of cases are driven by the nicotine that leads to smoking, heavy smoking, prolonged periods of smoking. That's what eventually triggers that damage in the lung that eventually leads to development of lung cancer.
And when it comes to lung cancer, Indiana's in a pretty tough space. We're not doing so well.
I agree. I'm a proud Hoosier, but the numbers are not in our favor. And if you look at statewide data from United States, in Indiana, about 72 cases per 100,000 population. So that kind of equates to almost 4,300 cases of newly diagnosed lung cancer per year. And to me, 4,300 cases is just not 4,300 cases. These are 4,300 families getting affected by lung cancer. And the difficult part is that the diagnosis, the staging, it's almost like a silent killer. So that's the difficult part, that our state kind of ranks almost 46th from the bottom as far as the incidence of lung cancer is concerned.
Yeah, that's not a great number at all. Now, we, as part of World Lung Cancer Day, I know your practice is promoting some cancer screening, some lung cancer screening. We're going to talk about that in just a moment. But I want you to know that we're going to give you a phone number, and we'll talk about what the conditions are in which you qualify for this screening. So that's coming up in just a moment. So what is it about lung cancer that makes it so difficult to catch it early?
It's a very good question, and a lot of times there's always that stigma that, okay, somebody has smoked and they end up with lung cancer. But the difficult part with lung cancer is that by the time you get symptoms, a lot of times the cancer has already spread out. So you can imagine that it starts as a small nodule in your lung area. Lung has a pretty big surface area, and that small nodules normally don't cause any symptoms unless it really gets big enough that it starts giving you symptoms. And the symptoms, again, when they start showing up, they're very non-specific symptoms. So cough, a lot of time it gets blown off because smokers have that chronic smoker's cough.
Yeah.
They don't pay attention to that. Hoarseness of voice. There is this one nerve that kind of gets affected, and smokers, again, with smoking, they have this a little bit of a hoarse voice. So you kind of blow it off. Weight loss, again, it's kind of a very non-specific symptom. So occasional blood in your cough. So these are kind of these non-specific symptoms that normally patients or even sometimes physicians don't think that, hey, this might be a cancer. And unfortunately, we are seeing younger and younger population where normally the word cancer normally doesn't even cross. Even physicians' mind, it doesn't cross that could they have cancer. So that's the problem with lung cancer, is by the time you get symptoms, a lot of times it has already spread into the liver or to the bones, and somebody comes to us with a back pain. And imaging eventually kind of figures out that, okay, it was cancer that has gone to the bones, and that's why the pain is happening. So screening becomes a big part now, and that's probably which I think should be focused on.
Okay, so we now know that screening is the most effective way to catch people early. Screening for cancer, breast cancer screening, 70% of women who are eligible typically are screened for breast cancer. What's that number look like for lung cancer?
So in lung cancer, unfortunately, again, the stigma with smoking and the screening part not being known much to general public. So in lung cancer, what we prefer is to screen high-risk patients. And there's a certain criteria, we can go over that, but unfortunately, if you look at the numbers, as you mentioned, that for breast cancer, 70% of women get those annual mammograms. In lung cancer, it's only 7%.
Wow.
So out of risk, I'm not even saying that all the population, I'm saying that out of high-risk population that are supposed to get screening for lung cancer, in state of Indiana, only 7% people get that screening done. So it's a very low number. And when we know that the benefit of screening for lung cancer, it reduces the risk of your dying from lung cancer by 20%. So that's a big number in oncology field. And only 7% population getting, high-risk population getting screened is something that I cannot boast as a Hoosier.
So that's why we are talking today, and World Lung Cancer Day is to bring focus to the need for screening. So screening typically is you're over age 50, you are a heavy smoker or a former heavy smoker, and they define that by something called pack years. Mm-hmm. And so that is, if you've smoked a pack a day for 30 years, that's considered 30 pack years. And that is kind of the criteria that they look for. And so walk me through that process. If I'm that person who has got that heavy smoking background, how do I go about getting screened?
Okay. So you mentioned the criteria very rightly. Anybody age 55, number one. Anybody, as you said, has a 30-pack year smoking history, so 1 pack per year for 30 years, or you think that, okay, 2 packs per day for 15 years, so 15 times 2 will be 30. So it's the amount of smoking multiplied by the years of smoking if you get that 30 number or higher. And then if you're an active smoker, or even if you have quit, but the quitting time is less than 15 years, you still qualify for screening. And normally when you get into that, and one thing is that you can actually go to some American Lung Cancer Association. They have these very nice calculators, algorithms that you can just put that information in, and it will let you know that should you be screened or not. Now, once you fulfill that criteria, then the first thing would be that you connect with your primary care doctors and let them know that, hey, this is one thing that I kind of want to check, that would I qualify for or not. And once you qualify, then it's a low-dose CT scan of your chest. And the reason I mentioned this low dose is that sometimes people get worried about the amount of radiation when they're getting these scans. So it's a very low dose, which equates to about 5 X-rays. It's nothing close to the radiation that people should worry about. And once a year for 3 consecutive years. It's almost the way our GI doctors say that you should get colonoscopy every 10 years or mammograms once a year for women. It's 1 low-dose CT chest, 3 consecutive years. And the data is very compelling that it will reduce the risk of people dying from lung cancer by 20%. And that's a big number, as I said before.
That is a huge number. We have so much more to talk about. We're seeing lots of advancements in treatment, and we'll talk about exactly what that looks like, what happens if you're diagnosed, what your choices are. Lots more to talk about as we focus on World Lung Cancer Day with Dr. Ahad Sadiq from Fort Wayne Medical Oncology and Hematology here on the Health Call Live Radio Hour on WOWO. And we are back to our conversation about lung cancer with Dr. Ahad Sadiq from Fort Wayne Medical Oncology and Hematology. We are talking today about lung cancer screening in association with World Lung Cancer Day, which is tomorrow. And if you'd like to be screened for lung cancer, it's a great idea if you have been a heavy smoker and meet some other criteria. You can contact your primary care physician, or you can contact Fort Wayne Medical Oncology and Hematology at 484-8830, 484-8830. They will work with you to figure out what is the cost going to be to you. Is your copay going to cover it? Does your insurance cover it? What exactly might that cost you? And then you can decide to move forward and have the screening. And it's a pretty simple process, right? It takes a little bit of time in your office.
It is, yes.
So non-invasive, never feel a thing.
Yes.
Okay, that's great. So let's talk about treatment of lung cancer. A lot of progress recently in just the past few years, right?
It has. It's been an amazing time as to be an oncologist at this time. The advances in oncology are mind-boggling. Lee, the point that I would like to make is that what we initially talked about, the lung cancer gets diagnosed at a later stage. So if you look at the data, normally when we see stage 4 lung cancers, meaning that the cancer has spread out from the lung, at that time, the initial diagnosis when it happens, stage 4 cases are normally about 55%.
Wow.
So that's a big number when you're talking about stage 4 diseases. Early stage diseases are that rest of the 40%, and stage 1 disease is probably about 20%. So the diagnosis, unfortunately, as I said, is that because the symptoms show up late, and majority of the cases are stage 4. But a lot of effort has been put in figuring out new treatment options. And as an oncologist, I'm very optimistic and very hopeful that I think things are moving in the right direction as far as research and new treatment options are concerned.
So if I am diagnosed with lung cancer, I am going to probably hear about something called personalized treatment. What is that?
So Lee, this is kind of that word that you hear a lot in cancer treatments, that you're going to have a personalized treatment plan. So over the last 5 years, this has become the truth now. What that technically means is that when somebody gets diagnosed with any type of a cancer, especially lung cancer, we are able to look at that person's particular cancer. We are able to look at almost 300 to 400 genetic mutations on that person's cancer, try to figure out what mutations they might have, which are considered as the driver mutation, that they're the reason why the cancer is growing in the body. And actually, with advancement in medicine, there are these, I almost call them as designer drugs, that those drugs are specially designed to act on those mutations. So you might end up with a drug that is only effective because you have a particular mutation. So that's why it's called a personalized treatment plan.
So I'm going to get the drug that is right for my type of cancer at the moment that it's right for me to have it, because cancer, these tumors are, they're not smart, but they do find a way to get around the effectiveness of a drug, right? They can escape the therapy.
Exactly. And these cancers are smart. Let me put it in this way. So think of this as that lung cancer is not just one cancer. It's a very heterogeneous cancer. Certain part of the cancers might have a different flavor. Some part might have a different aggressive flavor. You try to control one part of the cancer and the second part starts growing because it has a different mutation. So it's a very heterogeneous disease just within one cancer itself. So where we guys have been working is that how we can manage to control the whole disease and not let the cancer escape the treatment options.
I have studied lung cancer, of course, in preparation for our time together today, and I've read many times that it's important where you go for treatment, make sure they're offering clinical trials. Why is that so important?
So, Lee, that's a big part of what I do and what my practice does. This is how the advancement in science happens, that you pick up the cutting line option, that if something which is the standard of care, can you add on something on top of that can improve the outcomes for your patients? And previously, I would say maybe 5-7 years ago, these clinical studies were mostly available at bigger academic centers. In our region, people would go to University of Indiana or they'll go to University of Chicago. But over the last 5-6 years, we have built a very strong clinical trial profile where we are kind of one of the biggest clinical trial programs in the northern part of Indiana. And the other concern, I want to just put it out, is that a lot of people think that clinical trials are these placebo drugs or you're getting sugar water. It doesn't happen like that anymore. Everybody on most clinical trials, they get the standard of care therapy, which is an approved option. And then on top of that, you have that opportunity in getting that cutting edge treatment option that might become the standard of care over the next couple of years. So I always say that the first option that the patients should look for is that can they get something above and beyond what's available as standard.
So ask that question, yeah. And part of the clinical trial process brought us to immunotherapy, where we're actually turning up the immune system to help fight. Tell me more about how that works.
So, Lisa, very interesting concept in how to treat cancer. Last 3-4 decades, think about chemotherapies and trying to kill the cancer cells directly. Then last 15-20 years, these pathway-directed therapies kind of came out that can we slow the growth of the cancer. Over the last 10 years, or I would probably say over the last 5 years, this idea of immune therapy that, okay, a lot of times people ask me that why does my own body not fight cancer? It's a foreign bad cell in your body. Why does your own immune system doesn't fight cancer? So as I said in the beginning, cancers are very smart. So what we have been trying to figure out in medical oncology community is that can we make our own immune system or that patient's immune system strong enough and smart enough that your own immune system recognizes where the cancer is and tries to kill the cancer. And we have some very, very good responses in certain type of cancers, especially in melanomas, where honestly the survival used to be 3 months, 6 months in stage 4 melanomas. Now we have patients who are alive for 7 years, 10 years on these immune therapy drugs, which is unheard of that somebody from 3 months of survival has gone up to 5 years, 7 years of survival.
How's it coming along with lung cancer? What's my survival outlook?
So again, immune therapy has become the mainstay in lung cancer. For stage 4 lung cancers, this is the standard now, that anybody who is naive to treatments is a newly diagnosed patient. Immune therapy, there are always some exceptions, but in most cases, that should be the standard of care. That's what patients should get. So there is very promising data. What we hope for is that despite stage 4 lung cancers, where the overall survival still is not that good, but can we have some of these patients that can be long-term survivals where their immune system understands and learns to keep the cancer under check despite not being on treatment. So that's what the goal is, that can we get that immune system trained to the point where you can just have that cancer and it doesn't grow.
So cancer becomes just a chronic disease. That's a great thought.
That's what I hope for.
Yeah.
Yes.
It'd be nice if we get to the point where you die with cancer instead of because of cancer, right?
Exactly. I wish that we can get that magic bullet where we can cure these stage 4 cancers. But at this point, I think you're right, that we are almost getting to the point where we are making people live long enough that they don't die from cancer. They die from something else.
And the first step to having a successful outcome with lung cancer is screening. And once again, doctor, give us a last thought on the importance of screening and how you get started.
So, Lee, my last 2 points would be the best treatment for lung cancer is don't smoke. As an oncologist, I'm trained to treat lung cancer. I've been in this practice for the last 15 years in the field of medical oncology, but the best treatment is please don't smoke. And the second best part is prevention. And with prevention, as I said, if you are in that high-risk category, get yourself those once a year, 3 consecutive years CT scans. That does reduce the risk of dying from lung cancer.
And you can do that by either contacting your personal care physician and expressing an interest in that, or contact Fort Wayne Medical Oncology and Hematology directly. The number is 484-8830. You can also find them online at fwmoh.com.